So with an exploratory burr hole, this is really only done if you're way out in the boonies, you don't have access to a CT scanner, can't get the imaging, don't have neurosurgery, and the patient is crashing and burning. Essentially, the idea is you have an extremely high suspicion that the patient has some sort of extra axial hemorrhage and needs treatment emergently or will die, again, without other access to imaging or advanced care. So what you do is what you're going to identify is you're going to identify the ear. That should be your first landmark as you come up on your to identify where you would go. The reason you'd identify the ear is you want to make sure you make your a burr hole in line with where an incision would be. So what you find is the root of the zygoma right at the base. Then you feel that, stay within a centimeter of the ear. That way you don't hit the facial nerve. You'll come loop all the way around the ear and loop anteriorly in a large reverse question mark. That would be where a large incision would go should you need to make, or should a neurosurgeon need to make a craniotomy later. What you've seen marked here is, right here would be the root of the zygoma where the middle fossa is. That's the area where you'd see your middle meningeal artery. That is the scary area, the one that you would hit first. So we'll come over to this bony side. You'll see the root of the zygoma, essentially where the ear would be. So right here would be where we would go. So I'm gonna make a mark here. Be careful because the bone here tends to be pretty thin. So we're gonna put it flat here just so we get a good view here. Typically the patient will be sitting up or head of bed 30 degrees at this point. You'll want someone to help hold the head. So what you'll do is you'll make sure you have everything draped appropriately. You'll start drilling. What you'll feel initially is you might have the drill slide a little bit. Make sure you drill a pilot hole. And it's all about how fast you spin the drill, not how hard you push the drill. Once you have the pilot, it's going to be a little bit more difficult to drill through the outer table. Then you'll feel a little bit of pull and it'll get easy. That's the inner table. That inner table, or not the inner table, that's the cancellous bone. That cancellous bone is going to be really easy. It's going to be fast to spin through. Then you'll feel it start to pull you in. That pulling in is the inner table. Once you hit that inner table and that pull, make sure you pull back as you are drilling so you don't dive all the way into the brain. So that's a little bit more difficult. Make sure we'll get through that. And you pull back out. Don't do that. Make sure you spin your bone chips out. And then you can take a look in your whole site and see if there's any bleeding, if there's an epidural, or if there's any blue sort of finding there. If there's a blue finding, that's probably some bleeding underneath. You'll need to open that up.
Excellent. And we'll go through that more and the possible sites on our next video. Perfect. Thank you.